but the whole idea is that neuropathology isn't really part of standard neurology training anyway, but I ended up getting into it, and it's really helped shape not just the research, but also kind of how I think about these diseases and how I think actually some of our field is starting to head in a more serious fashion anyway. So I was gonna skip this a little bit because this has more just my personal timeline. And what I was kind of asked to do was talk a little bit about my like research journey anyway, but also some of our work. So I am trying to like intersperse a little bit about career stuff as we go. Hopefully this will be useful, but it's good to know that we're mostly a PhD audience anyway. But yeah, I did neurology residency and fellowship in Philadelphia at the University of Pennsylvania. And I'll talk a little bit about this master's thing that I got at the end of fellowship, and then came out here for my assistant professorship in 2019 and have been here since anyway. And over time, like the work has changed. I'd say that from the neurology standpoint, I started getting into movement disorders, which is one of our subspecialties, because I really thought that neurodegeneration was intellectually interesting. Anyway, the patients that we saw who had these disorders were compelling, very serious illnesses, and I wanted to understand more, I guess, about it. And within neurodegeneration anyway. Probably the two subspecialties that take care of these people the most are movement disorders or cognitive behavioral neurology. Now, within movement disorders neurology, we don't just do neurodegenerative disease, but yes, we take care of a lot of Parkinson's. We take care of a lot of atypical Parkinsonian syndromes, including multiple systems atrophy, progressive supranuclear palsy, cortical basal syndrome, and others. But there is a lot of variety, and we get to see a lot of non-degenerative things too, like genetic disorders, like many ataxia syndromes, dystonias, acquired things like drug-induced Parkinsonism for people who are on dopamine blocking medications for long periods of time, or tardive dyskinesia. And on the practical side, we do medical management. We prescribe medications, change them, trying to get the best results we can for our patients. But I also do deep brain stimulator programming and Botox injections for movement disorders. So it makes your clinic day nice and varied anyway. You get to break up some of the harder conversations, the more serious stuff with things that are a little more, procedurally based. And this morning was actually kind of a good example of that. Some people had some very heavy conversations with, but then there are some people I got to see who are doing pretty well and were pretty short visits actually. So when I got to Movement Disorders Fellowship, one thing that always really bugged me was that sometimes we didn't honestly know what our patients had. I mean, in a nutshell. Yes, you would see PD, Parkinson's, or DLB, PSP, whatever, guys. And there were definitely people who were like, okay, this is pretty clear. This is what you have anyway. Um, but there are plenty of cases where people were not totally sure. There's the Parkinson's patient who has so much autonomic instability that you think they might have multiple systems atrophy, or maybe they're older and they don't respond great to levodopa. They have early balance impairment, and we're wondering a little bit about PSP in the background. And there are very few tools at that time to help differentiate these conditions. Um, and when we would go to these clinical pathologic correlation sessions, when people who had donated their brains, anyway, we got to look at them under the microscopes and everything, and you could see what people had. To be honest, we were wrong, often in some cases. So the numbers that are like put here are from some, older papers anyway, but that's when people used to publish more on this type of topic of how accurate are clinical diagnoses during life when matched against neuropathological findings of that kind of disease in cohorts of folks who had gone on to donate their brains. And in some instances, the numbers are quite low anyway. And that always struck me as being totally unacceptable. Like, how are we going to, treat and eventually cure these diseases if we don't even know what's going on in front of us anyway? And that was kind of a thing that really started pointing me towards neuropathology as something I wanted to get more involved in. Thought that was sort of a major inflection point with where I wanted to go with the work. So working in people who had donated their brains anyway, you at least knew what they had. So you can do better studies of how they behave during life, whether that's clinically or what kind of biomarker signatures they had. So, the University of Pennsylvania has an extremely strong neuropathology program. It's run through their Center for Neurodegenerative Disease Research, anyway. And by really influential people in the field, John Trojanowski, who passed not too long ago anyway, his wife, Virginia Lee, who was more on the animal model side of things, Murray Grossman, who also passed not too long ago, Dave Irwin, who was my big mentor anyway. They had a very large brain bank, very systematic with how they did their assessments. And it was just a great resource anyway. And these are some examples of what we would do anyway. And you would get these brains, and the tissue core would stain up the slides looking for synuclein, amyloid beta, or tau. We would get to look at these things under the microscope and start actually doing some of the staging and say, like, okay, well, this person had Lewy body pathology in these regions, had tau pathology in these regions. Let's put it all together and figure out what their staging is supposed to be for these things. The CNDR was very open. They were very happy to have non-pathology people do research with them, and they would even give us cases like we would do now to our pathology colleagues. We would read them and then sit in the microscope with people like John Trojanowski, and basically we would give them a rough draft of a report, and they would fix it and tell us what we were doing wrong, and give us some teaching points about neuropathology as we went. So that was really a good organization to be a part of. And I did really have to reach out to them because there was nobody in movement disorders at Penn who was really doing neuropathology-based work. It was really through the CNDR, a really whole different area of the university that was doing this type of thing. But fortunately, we found open arms over there. Another part of the inflection point was that I was finishing my clinical fellowship within movement disorders is either 1 or 2 years, depending on where you are. The Penn program was 2 years, but there was this option to pursue a master's in translational research program. Um, and this was funded either by T32s or KL2s, depending on who you were and what department you were in anyway. Through the neurology department, it was T32 funded anyway. And the people who did these master's programs tended to be either like fellows or maybe early stage attendings. There was a MD MTR program where there were medical students who were pursuing both of these things as part of a 5-year combined program. So that was always fun because we had like, the old people like me who were in the room, and then the young and youthful like med students who were always fun to work with also. I ended up doing this and interleaving it with the fellowship. So it ended up having 3 years as part of my fellowship. And the T32 was the mechanism that funded me. That was kind of important to me anyway at the time, just because you only get so many years on K awards through the NIH. So if I had been on a KL2, I would have burned through a couple of my K years during this. But that's it. Fortunately, I didn't have to worry about it too much. The T32 took care of me. And the nice thing about that program is that it offered protected time to be able to do this type of research, and also had a bunch of practical didactic courses. I mean, it was very much like you could do your grantsmanship course during which you would write a grant, statistical analysis work where you would bring your own projects in and we describe the data and talk about which, tests and how to do them were going to be the most appropriate. There are similar UCSD programs anyway. The REC program has some stuff. The CREST program has some like a la carte, very practical programs at UCSD that would fit this bill too. I'm sure you guys get like pretty high-end stuff through your PhD programs as well. The ACTRI has a KL2 program that has parts of this too. So there are like similar programs set up here at UCSD that people can take advantage of if they're interested. But after we started actually doing the research, actually starting to look at more and more cases, more and more slides under the microscope anyway, we start uncovering another uncomfortable truth, which is major point number 2, that the large majority of people don't have just one pathology. Most people, if not nearly all people, have more than one thing when they pass away when they're older. All of these like bar charts on the left side are actually from Penn CNDR database back in 2018 when they started looking at what are the rates of co-pathology in our different diseases. And say, let's just work on the blue guys here. So if you looked at somebody who had intermediate or high degrees of Alzheimer's disease, there's approximately a 50% chance that you have some amount of Lewy body pathology, alpha-synuclein pathology in the brain anyway. And maybe that's down to 40% or so in your intermediate Alzheimer's, but 10, 20, 30% of some of these other more rare neurodegenerative diseases. Amyloid is very, very common across pretty much all neurodegenerative diseases, reaching rates that are at least 40% in your aged population, and some a good bit more than that, too. Um, those are sort of breakdowns by pathological spectrum, but if you look at them broken down by their clinical spectrums and just the number of neuropathologies that are present, like almost it's, yes, you have a couple of people who have one pathology, like the MSA and the ALS guys, but most people have two or more, to be honest. And of course, the more pathologies you have, just as sort of a gross statement anyway, the more pathologies you have, you probably aren't doing as well, especially cognitively anyway. The bottom graph, though, on the bottom right is actually not from any of UPenn's data. It's actually from Claudia Kawas's group at UC Irvine and their 90 plus study anyway, where, of course, they see a fair amount of co-pathology as well and its influence on clinical outcomes. Okay, so if people were working on neuropathology because we like knowing what people exactly have, and now we're confronted with the truth of, hey, people usually don't have just one thing. There's other stuff going on. So how do they interact? That had become a major question that I started to work on with some of the other people at Penn as part of that master's program. And mostly it was centered around the interactions of Lewy body pathology and Alzheimer's disease anyway. Mostly from a Lewy body sort of like lens, I suppose, because I was a movement disorders person, seeing more Parkinson's disease in our clinics anyway. And we wrote some review papers and did some of our own work. And I think that what we generally see is that people who are non-demented Parkinson's patients don't have super high rates of Alzheimer's disease co-pathology. But as you work up into things like Parkinson's disease dementia, the rates of having significant AD co-pathology jump to about 30 to 50%, depending on what cohort you're looking at. And if you have dementia with Lewy bodies, it's like 70 or 80% of them have like significant and high levels of Alzheimer's disease co-pathology. Um, and people who have those types of mixed pathologies, besides being more likely to be older at onset, they certainly do worse cognitively over the longer term. In the Parkinson's patients, they may be a little bit less likely to have tremor anyway, but there's a pretty clear difference in their phenotype, especially as it relates to cognitive progression over time. Not just in global metrics like DRS or MoCAs anyway, but also sort of specific profiles. And they are profiles that you would expect, more episodic memory and naming problems out of the people with co-pathology of the AD type and, more sort of working memory, attention, visual, spatial stuff, and those who are more Parkinson's or Lewy body centric anyway. Another wrinkle to think about that we also started tackling was that the way that we measure neuropathology, even though it is gold standard, is fairly coarse. I mean, we're taking pretty small sections of brain and looking at 5 to 6 micron thick slices and making like extrapolations about what might be happening elsewhere in the brain. And the way that we quantify this is also pretty coarse. And most people use many scales are kind of built on a mild, moderate, or severe presence of pathology. Um, and that's very subjective. Sometimes there's some guidance about how to make those designations in an objective fashion, but mostly it's kind of left up to the neuropathologist and their opinion, whether like how many Lewy bodies constitute sort of a moderate amount versus a severe amount anyway. So, and people have looked at this in a couple of studies anyway, and looked at the inter-rater reliability of neuropathology people. And, the scales wobble. They're a little bit different depending on who's looking at the cases anyway. So that's a little bit of a problem too, especially if we're going to treat this as the gold standard. And if you're going to have your your outcome variable be something so coarse as mild, moderate, or severe anyway. So there was a person also at the University of Pennsylvania who was doing more image analysis work anyway, and that's something that I learned from him. This is Dave Irwin's work mostly. And the whole idea is to start leveraging computerized tools to help measure the density of pathology in a given area. And in some ways, it's really quite simple. You stain the slide for whatever you want. It could be tau, A beta, synuclein, TDP43, whatever, as long as there's a decent signal to noise ratio on the slide. You scan the slide, which is we have some slide scanners here at UCSD. Some are in individual labs, and there's a big one over for the at the Center for Advanced Laboratory Medicine. And that gives you a really high resolution image, big image file, usually 2 GB per slide or so. And then you can use different software packages to sort of draw what area you want to look at and start telling the computer what you want it to detect. And usually with standard immunohistochemistry, you're trying to tell it to pick up brown things anyway. The amyloid beta plaques are sort of the easiest to work with. And you can see sort of one of our detection algorithms trying to pick up all the plaques in that given box there anyway. And this will give you an output number. Usually that's described as a percent area occupied. So if you look at, I'll show you some more examples in a second of this. But this is now some of the workflow that we do in our lab when we're doing this kind of work. And this is a scanned image of a hippocampus of somebody who had pretty bad Alzheimer's disease. And this hippocampus has been stained for phospho-tau using the PHF1 antibody, it looks like. And I can tell that because I am reading the title on the left side. But hippocampus is beautiful. You can see the dentate gyrus. Using my pointer. I wonder if you guys can see that or not, but nice little dentate gyrus there, and all the really abundant neurofibrillary tangles you can see even at low power. So if you zoom in, we're going to draw a box real quick here. And the first thing we usually do is try to figure out what shade of brown we're looking at. So thankfully, most of the programs have some automatic detection things to tell you exactly like, are we doing light brown? Are we doing dark brown? How good was your staining this time around? So you're basically telling it what kind of color you want it to detect. And then you zoom in and we start applying some of these masks to try to see like, okay, let's pick up the brown stuff. Let's make sure that we're only picking up brown of a certain intensity. And if the threshold is too low, we're going to start picking up a lot of background garbage anyway. So we get to visually tune this. And then we can zoom in and start applying some of these algorithms to whatever piece of the tissue we're interested in. We're over here in sort of the transentorhinal cortex. So I had picked out sort of a long piece of straight transentorhinal cortex anyway. And then there's a random tiling method that we like to use, which helps cut down at least on layer bias, which is something that you might notice is that with neurofibrillary tangle pathology, it likes to live in certain layers of the neocortex. There's a whole lot in like the superficial layers, and then there's a little bit of a gap, and then there's more stuff in sort of layers 4, 5 usually anyway. Cool. And here's kind of a zoomed in picture of all the different tilings and picking up some of this neurofibrillary tangle stuff. The blue guys are just cell bodies. Those are just little neurons and astrocytes and oligos in the background. But we usually do like a counter stain for those things and just tells us a little bit about the cellularity that we're looking at. Um, But the real benefit to this type of work is that you get a much more granular sense of how bad, how severe, how dense the pathology is. And it can really help you do like much more advanced statistical modeling. So we initially used this just to sort of explore some of the patterns of synuclein and tau pathology in Lewy body disease anyway. And the bar graphs at the left were from work that we did in 2019, looking at neocortical and subcortical Lewy body density in people who had relatively pure DLB or PD versus those who had AD copathology. The big take homes being from the left, pink and purple guys, is that you get higher degrees of neocortical synuclein pathology if you also have co-occurring AD pathology anyway. The box on the right, we were actually comparing the tau burden between our co-pathology guys who had DLD or PD versus those who had a pure Alzheimer's disease. And this is pretty interesting, I think, and I think is very much overlooked in the literature. The Alzheimer's guys have way worse tau pathology and like way, way worse, like several folds higher than even the tau pathology that we see in DLB or PD when it occurs. I think that personally that there are echoes of this in many, many parts of the biomarker literature, including PET studies, which are pretty bland in Parkinson's and DLB, in biofluid biomarkers also. I think this is something that neuropathologists kind of missed by using sort of older techniques anyway, but can't prove that all yet, but that's just what I'm going to say. Yes, we did some other stuff also with hippocampal subfields. You can, basically dissect out what regions you want just using imaging instead of, forceps and everything. And we did some nice stuff trying to look at Lewy body and Alzheimer's pathology and different hippocampal subfields in Lewy body disease and Alzheimer's cases as well. So you can get a really nice version of patterns of pathology. But the other side to this work is that you can also do much more powerful examinations of how does pathology relate to in vivo biomarkers. So this is part of the same project where we were trying to look at correlations with cognition anyway. We had a bunch of people who had MMSEs. There was a decent correlation with their neocortical tau, but no major correlations with amyloid beta or alpha-synuclein. We had DRS scales on a subset of folks, and then we saw also a pretty strong correlation with neocortical tau pathology. Category fluency, which if you had to pin it down, is probably more of a frontal lobe mediated task, and you guys can tell me if I was totally wrong about this, but it also correlated with tau pathology in that area. And the Boston naming test being more of a sort of temporal area type thing. Same story. So using this sort of digital image analysis approach anyway, we saw very, very consistent associations with tau and cognitive performance, and actually really remarkably consistent across many different types of cognitive measures, and a really lack of correlation with these other neuropathologies that were occurring at the same time. But pathology type work lends itself to kind of, I don't know, mercenary collaboration type work. So we've done work with other groups that have been looking at MRI measures. For example, this was an MRI project where somebody wanted to look at the neuropathological correlates of MRI atrophy. So we helped them with that. This was a great little case report anyway that we did on a patient who had a really interesting clinical syndrome that was hard to diagnose. It was kind of emblematic of what I was talking about in the first couple slides. Is a 64-year-old man. He had really bad left visual hemi-neglect with apraxia. And I think that the person who saw him first thought that he probably had cortical basal syndrome, but a few years in, he also developed really bad Parkinsonism and visual hallucinations, and tremor dominant Parkinsonism as well. So they had been mucking around, maybe thinking that maybe he had dementia with Lewy bodies with kind of an odd presentation. This particular person was ended up wanting to participate in a lot of our biomarker studies back then. So they had fluortaucipure PET imaging, which some of the pictures are shown in this top sort of fluorescent thing here. And what you're meant to see is that this is a very positive fluortaucipure PET, and that the tau pathology is pretty lateralized, that it's definitely more so on the right side of the brain than the left, which corresponds to his left hemi-neglect and apraxia syndrome. This person passed away and did donate their brain to our brain bank. And at the time, we had a kind of a unique one-off initiative where we were actually doing histo work on both sides of the brain. Under normal circumstances, we usually freeze half of the brain and then use the other half to do the immunohistochemistry. But for these guys who had sort of FTD-like syndromes, we were at the time, people had been interested in laterality with all of this stuff. So we were taking slices from both sides. And what we ended up seeing was that there was really, really heavily lateralized tau pathology corresponding to the PET studies, but there's also pretty heavily lateralized synuclein pathology also, which isn't something that gets routinely seen at autopsy. So I thought that was really interesting. Amyloid pathology was pretty boring and very symmetric anyway. So, I finish the master's program and looking for jobs after that anyway, as a young MD anyway. We ended up looking in San Diego because of a lot of family motivations and everything. Um, so my wife, her family lives up in Orange County, and we had been on the East Coast for what, 7 years or something at that point. So she really wanted to be closer to them at that time. So we focused a lot of our job searching in Southern California, and UCSD was a great place and had a lot of the resources that you potentially could have to continue this type of work. Um, Money was a thing. Like I didn't have much in the way, but I was like fortunate enough to have gotten a AAN clinical research training grant, which is the American Academy of Neurology. It was 2 years, $150,000, $75,000 per year. And there was a mandatory thing with it where you had to spend 75% of your time on research. And the grant was to continue some of our work of these digital pathology measures in cognition, Alzheimer's, and Lewy body disease. So that's not like a ton of money, and with a stipulation of having to do research, it basically protected my salary enough, so that I could make a plea to department leadership to allow me to do this type of thing anyway, and stay in clinic like about 1 day a week. But a question was going to be like how to do the work because this is not enough money that anybody who's going to grant me like my own lab space or anything like that. So that was challenging. And to be honest, I didn't get a lot of help, but what was helpful was NIH Reporter. So I was actually kind of like Googling around on NIH Reporter trying to see like who at UCSD does stuff like this anyway. And I found Annie Hineker, who used to be a neuropathologist here. She's since moved on to USC. And I cold emailed her and was like, hey, Annie, nice to meet you. My name is Dave Coughlin. I'm a neurologist who does this kind of neuropathology work. Can we meet? And she was great and basically allowed me to kind of be in her lab. So I had the space to do stuff. I mean, I was bringing my own money to pay for supplies and small amounts of equipment, not much, but like enough to do histology, which doesn't require a lot of resources at the end of the day. But Annie was wonderful, and I would not have been able to continue this type of work without her. Anyway. Um, Being in a new place like UCSD also, UCSD is got different strengths anyway than UPenn. So I found myself pivoting a little bit as well. The ADRC is really the largest program project here in the neurosciences department and did the most similar types of things where following people clinically, getting good in vivo biomarkers, and they're the gatekeepers to the brain bank by and large anyway. And then about mentors here, like Doug Galasco is a neurologist on the cognitive behavioral side, and he's got way more expertise and access in the biofluid biomarker side. So we started pivoting a little bit more from doing all neuropathology side stuff to doing more in sort of the biomarker pathological correlation side of things. And during this transition, anyway, this is where the ADRC's rec program was also helpful because they also, I applied for this and was fortunate enough to be awarded a small pilot grant that also helped cover some of my time to sort of make this transition anyway, which is really critical, especially when you're early on and just trying to get started on your own. And that project that we were working on through the REC was going to be the neuropathological and cognitive correlates of something called alpha-synuclein seed amplification assays. So many of you have probably heard of this, but just in case you haven't anyway, CSF alpha-synuclein seed amplification assays have been under development for the past 7 or 8 years now anyway. They are assays that are built off of the backbone of prion disease type tests anyway, where basically you add a CSF sample into a well that has a lot of alpha-synuclein monomers in it. And if your CSF sample has a misfolded aggregated synuclein seed that's capable of templating, and you drop it in, it's going to do that. It's going to make the monomer, recruit the monomers into longer and longer fibrils. And if you let that process happen for a little while, then you shake up the well or break it up in some fashion, sonication or shaking, either one works. And you do this again and again. Eventually, you create enough of mass of fibrillar protein that you can detect it using thioflavin fluorescence. And there's a cartoon from one of our review papers where you can see like this is what the fluorescence curve might look like over time in a positive sample that contained a seed. This is just to say that there's been a whole lot of effort and a whole lot of studies that have been done over the last 8 to 9 years now, I guess, that really show that this test, this technique is really pretty darn sensitive and very specific in detecting synuclein seeds in the setting of Parkinson's disease, DLB, multiple systems atrophy, and that you even find, considerable positive rates in prodromal types of situations. People who have conditions like hyposmia or idiopathic REM sleep behavior disorder, which we've known from some older natural history studies, are states that are highly, highly likely to go on and develop Parkinson's or DLB in the future. And a very good story to be a part of. However, nobody had really done any work comparing CSF seed amplification assay work to neuropathological findings. So Doug and I and the people from Oregon Health Sciences University and the folks at Amprion, who is a commercial company who do this test, they have labs in San Diego, by the way, and their research and development team is very good to work with. We had assembled a case series basically of 100, nearly 119 people who had antemortem spinal fluid testing. And then we had their brains, so we got to look at the degree of Lewy body pathology over life. And our big contribution here was saying that, hey, if you had neocortical or limbic stage Lewy body pathology, this test is remarkably sensitive. You're getting positive rates in the spinal fluid, even if it's a few years ahead of death. That's almost 98% anyway. But if you looked at more restricted versions where you have a couple of Lewy bodies in the amygdala, the test isn't as sensitive. Only, 14-ish% of those guys had positive tests. So it was telling us a little bit more about what are we actually detecting? What at least is the general degree of Lewy pathology that is probably happening in the brains of these people when we're sending these tests off of the spine. But anyway. We've gone on to do some collaborations looking at seeding activity directly from brain tissue. So yes, you can use CSF for this, and people are also trying to adapt these types of platforms to, more benign matrices like skin or even blood. But I think that it's kind of fun to work directly in brain tissue because this tells us a different aspect of the pathology that's happening. And some of these partnerships have gone on with Amprion, but also academic laboratories like Alison Krauss at Case Western Reserve University, who has been a remarkable collaborator there. She does her own version of these seed amplification assays. She's been pretty focused on tau for a number of years and is starting to make a change back over to synuclein. We provide them with tissue, we provide them with neuropathological expertise, and some of the things that we've found anyway is that, basically that brain seeding activity correlates pretty darn well actually with histopathological burden. We're starting to do a little bit of a deeper dive into other unique pathological modifiers that may lead to increased seeding activity, different post-translational modification work anyway, the presence of different co-pathologies. These are all very good. But these types of projects were the ones that I wrote into my K23. So after the ADRC rec anyway, I had been at UCSD for about 2 years, year and a half anyway. So those other grants, the smaller ones, were coming to an end anyway. And I did use that year and a half, 2 years anyway, to really kind of put my head down and get enough done so that I could apply for an NIH Career Development Award. And Didn't get it on the first time, but got it on the second time. So that was great back then. And kind of since then, we've been moving, into other live cohorts, to be honest, people who don't have as much of the neuropathological stuff because we've done a lot of that good foundational work initially. Here's some papers from last year about us looking at CSF seed amplification assay results in people with dementia with Lewy bodies anyway, and some of the differences between clinical features that would predict synuclein positivity versus negativity. Probably the single big take home that I took from this is, well, two, I guess. One is that a lot of people that we're calling DLB don't have synuclein pathology. In this big study, it was about 70%, 73%-ish of people who are synuclein positive. So there was a lot of people that we were calling DLB who probably don't have that. The other thing is the big take home. If there's a single test to really guess if somebody was synuclein positive or negative, it would be a smell test. Objective hyposmia based on University of Pennsylvania smell identification test. That's the red line. Sorry, I should have put like a legend. I'm sorry. So the red line in that ROC curve on the bottom left is like the predictive ability of just the upset, the smell testing percentile. And that's AUC was like 88% by itself as a single thing. The green item was actually the MoCA scores. And the blue one was the MDS-UPDRS scale, which is a measure of how bad is your Parkinsonism anyway, your stiffness, slowness, and tremor features, which did not perform very well. We got a research paper accepted, not published yet anyway, trying to talk about some of the research applications and clinical implications of using these new synuclein biomarkers. We'll talk more about that later. But we've also been taking a look at CSF amplification parameters, like basically trying to look at if people who have faster seeding reactions, if there's anything different about them compared to those who have slow seeding reactions. The survival plot on the left was looking at some of the prodromal PD cohort from the Parkinson's Progression Marker Initiative study, which is a really big, well-funded Michael J. Fox initiative. And pretty clearly, what we saw is that the people who had the fastest seeding reactions were the most likely to develop Parkinson's disease in the next couple of years. This was followed by sort of the people who had positive tests, but they were slower seeding reactions. And then the people who had negative seeding reactions, like hardly any of them phenoconverted over the course of 9 years of monitoring anyway. We have a kind of a preliminary look at a dementia with Lewy bodies cohort and looking at predicted change in MoCA and Parkinsonism over time between fast and slow seeders for people who've had this test. And it looks like the people who seed faster do worse on their MoCAs over time and do a little bit worse on their UPDRS parts 1 and 2 over time. It doesn't seem to have as much of an effect on the motor stuff, but it's kind of interesting. And we're just starting a project trying to take a look at differences in speed of seeding reactions in different clinical cohorts. We have some work from Dementia with Lewy Bodies cohort, but also the Alzheimer's Disease Neuroimaging Initiative. We got a hold of some data, and the speeds are pretty different. The ADNI guys are the ones that are in blue, and the DLBC participants are the ones that are in red. And granted, the numbers are fairly different. We're going to try to fix that in the next couple of months, hopefully. But the speed of these reactions, even though it's the same assay, are fairly different depending on what condition you seem to have anyway. But now the last thing I think I was going to talk about here, as far as like research work, is, we talked a little bit about how Alzheimer's pathology is common in Lewy body disease. We started looking a little bit more heavily at in vivo Alzheimer's disease biomarkers in Parkinson's disease and dementia with Lewy bodies to try to get a better handle on how these people are different from each other over the course of their life. So the column on the left is a similar type of analysis looking at people who are synuclein positive and amyloid positive DLB participants versus synuclein positive amyloid negative DLB participants. And basically, again, the people who have co-pathologies, their MoCAs get worse much faster, and their MDS-UPDRS parts 1 and 2 also get worse faster. There's some preliminary work I think I can share on the right anyway, looking at plasma p-tau 217, which is a blood-based Alzheimer's biomarker in Parkinson's disease. And at least the Parkinson's participants who have the highest degrees of p-tau 217 at enrollment they're more likely to have more precipitous cognitive decline over the next several years. Greater likelihood of needing functional help anyway, dependence on others anyway, a little bit more issues with mobility as a whole through the Honeyar scale. Not that much influence on overall motor progression, but again, more cognitive and functional outcome problems than not. Over the last couple of years, I've picked up a couple of extra roles anyway, including managing the neuropathology core. I actually help to manage our clinical fellowship now, at least for now. And I also do like some biomarker working group stuff with a Parkinson's study group. Do you guys know the plane? Does anybody recognize this cartoon? Yes, no.
Yep.
Good. Since I
That's
was
where you would have put all the armor, right?
Yeah, that's right. So, for those who might not be familiar, anyway, this is a statistical story anyway from World War II. And the guy's name was Alan Wald, I want to say, or something like that. But the idea was Allied forces asked this guy to say, like, okay, where do we want to put the armor on our planes? Here is a whole bunch of planes who've returned from battle anyway, and here's where their bullet holes are. So there was a group of people who said, hey, we should put armor over the red spots anyway. That's where they're getting shot anyway. But our statistician friend, Alan, I think his name was like, no, that's not right. We want to put armor on the places where there aren't bullet holes because the planes that we are looking at now are the planes that made it back. So presumably the planes that are getting shot in these other areas are the ones that didn't make it back. So we want to armor those areas. So I like it too. So when I was kind of asked to like give a talk that talked a little bit about like my career and my research, I thought of this because like I hope you find this helpful, I guess, but like when I've heard other people give this talks, I was like, okay, well, these are the guys who made it also. Um, so under this lens, like, there are things that I could do better and don't do terribly well, but I seem to be plugging along personally. Like, since I wear these different hats, I think that something that students and faculty alike have to sort of balance their responsibilities to clinic research and administrative tasks. It's a challenging thing. I know that I am personally given to like a fallacy of time management where I like to get little things done quickly anyway. So I get that sense of accomplishment and I sometimes neglect like larger projects that maybe will take more days because it takes longer to do them. And then it is always for me a balance between wet lab and dry lab stuff. But as far as like critical hits that have allowed me to continue this work, I was going to say kind of these three things that have really helped me. The ability to sort of get into research in a more serious fashion, which happened mostly during fellowship and during that master's program, and getting early mentorship at Penn through the CNDR, Dave Irwin, having really supportive people to help with these first steps anyway. Another critical transition was coming over to UCSD, where I had a little bit of grant funding and finding good people to help and at least let me get some work done to kind of launch into career development like Strata anyway. And Annie Hineker was a big part of that also. And then the last part is one that I'm living right now is that my K-23 is coming to an end and trying to figure out what life looks like beyond that. R01s are in the mix. It's not a great time to be doing that, but you don't always get to choose your time, I guess. But yeah, between Fox Foundation and other initiatives, this is another critical period. And these are just things that I think can resonate, I hope, with other people who have similar types of careers too. But I think that, common through lines is having good mentorship and people to look out for you as you sort of like negotiate these especially fragile times anyway.